Assalamu alaikum. Thank you to the organizers firstly for inviting me. After Dr. Saima Muzahar's talk yesterday, very comprehensive session on PRRT, I'm not sure more I can add in these 15 minutes. So my topic is about neuroendocrine tumors and lutetium dotatate and the real world experience and lessons learned. So I'm going to kind of whisk through the initial bit, which is neuroendocrine tumors and its imaging and therapy, and try to talk a little bit more about the challenges we face day to day when we give this treatment to our patients. So these neuroendocrine tumors, they are rare, highly heterogeneous tumors. They have overexpression of certain receptors, and about 45 to 65% are in the gastrointestinal tissue, followed by lung and pancreas. The classification. What we want to know about is what is relevant to us is the grading. It goes from 1 to 3, which is from well differentiated to poorly differentiated. And we're also interested in the Ki-67 when we treat these patients, where grade 1 has Ki-67 of 2% or less, and grade 3 of more than or equal to 20%. So imaging algorithm, suspected NET, they generally tend to have morphological imaging followed by functional imaging, tissue resection or biopsy. It can go the other way around as well sometimes. So in the interest of time, I'm not going to go into much detail, but if there's anything you want to take from the slide, radiological imaging is very much involved in the initial diagnosis and sometimes in follow-up. These neuroendocrine tumors are arterially enhancing, so when you request imaging, you should ask for triple phase. Yeah. So what are somatostatin receptors? Based imaging, somatostatin is a peptide hormone, and they bind to somatostatin receptors, which are from 1 to 5. Type 2, followed by 1 and 5 are most highly expressed, and they're abundant in neuroendocrine tumor cells, which make them an ideal target for imaging and treatment. So why do we want to image them? Because it helps us accurately stage these patients, determine the therapy options, monitor the therapy, and to see if there's any relapse or recurrence. The functional imaging modalities, the last decade, dotatate PET-CT has kind of shown that it's much better, as in it takes less time, less radiation, and better resolution than octoscan. So where available, that is being used more frequently. The management would depend on the grade of the tumor, somatostatin receptor expression, and this guides the clinician towards the treatment option, which are many. And so talking about lutetium dotatate therapy, lutetium radionuclide is chelated to a peptide emitting high energy beta particles and gamma rays, and it's designed to target somatostatin receptors, which are overexpressed in approximately 80% of neuroendocrine tumors. What is the mechanism of action? Intravenously it's given, it concentrates into the size of neuroendocrine tumors, and it binds to type 2 receptors, and it's internalized and emits the radiation. Most commonly indications are, you have to have positive expressions of somatostatin receptor, and it's disease metastatic, inoperable, increasing symptoms, or disease progression while on maximum somatostatic analogs. Ideally, we want to treat grade 1 or 2, and Ki-67 preferably should be less than 20%. There are some contraindications, and absolute and relative. Then there are recommended lab thresholds for PRRT. I'm sure most of you are aware of them. So when we want to start the treatment, the most important thing here is that to address patients' and team's expectations. This treatment is going to be over quite a few months. It's expensive, especially when the patient is paying. So they need to have a realistic idea of what to expect at the end. They should know that at some point we may even need to stop this treatment, and how we're going to be monitoring the disease. by doing their bloods frequently and the scans after the therapy. So, along with the history and physical examination and imaging, the things to look for, we like to formally document their GFR and check about urinary continence and explain radiation protection issues. We want to check the level of their control of diabetes, because we do like to give steroids cover. If they're on heart failure, we will try to restrict the fluid given. So after pre-therapy bloods, IV antiemetics, steroids, for renal protection we give amino acids. Lutetium is given, and it's quite variable. As we were discussing earlier, different centers like to do different things, so I won't go into numbers. So it's generally given a slow IV over 30 minutes. We like to have a physics colleague involved. During the right after treatment, the next day we like to do whole body, and we also like to give post-treatment steroids. Every setup has their own room or whatever is available and equipment to deliver the treatment. Side effects are most commonly seen while the patient has treatment is nausea, delayed. More commonly seen is bone marrow suppression, which is luckily temporary. So we want patients to understand that it's only 2 to 6% will have complete response, and there is partial response in 9 to 29%, and we are very happy if we manage to stabilize the disease. So lots of data now showing good results over a long period of time. We assess response in different ways, follow up with bloods, post-therapy scans, after treatment's finished, doing gallium dotatate PET-CT 3 months and 6 months after the last cycle. I think this is something everybody's quite familiar with, so I won't go into a lot of detail. Letter 1 trial, which showed that patients receiving lutetium dotatate with long-acting octreotide 30 milligram, they had much better progression-free survival and rate of progression-free survival at rate of progression at month 20. This led to the FDA approval. So talking a little bit more about the everyday practice of giving treatment to these patients. The first challenge is when we're choosing the patients. So different parts of the world, even in the same country, different departments have different criteria. Setting up, for example, we can only do here in Choktanam patients of gastroenteric pancreatic endocrine tumors. If not, then we have to kind of prove with data to get permission to treat those patients, which we do get because I think there's sufficient data available. Some other places, they have more freedom and they can treat whoever and however they like. Then also when we are deciding treatment, when it's clear-cut, nicely avid dotatate positive disease, and we can confidently treat them. But when and then 3-4, when there's a bit of FDG uptake and dotatate uptake, that requires a more clinical discussion in MDT to decide. So as I said, when we are planning their treatment, we need to see the patients on long-acting somatostatin analogs, and they should be not be administered for at least 4 weeks before our treatment, and then they can be given 4 hours to 24 hours after cycle. Short-actings can be given up to 24 hours. So during treatment, most commonly we see the patient gets a little bit of nausea while they're having the administration of lutetium. We found what helps sometimes is just kind of slowing down the infusion and let the symptoms settle. We also advocate ginger sweets. They help a lot as well. Extravasation, though rare, does happen, and very rarely is the net crisis. If it does happen, you need to stop the infusion immediately, and if needed to treat with octreotide. Extravasation we try to avoid at all costs, but if it happens, the infusion must be stopped immediately, and depending how much it is, maybe just lifting the arm and keeping it warm may help. Sometimes really you may need to get it aspirated. So once therapy started, between cycles, we look out for hematological toxicity. Most of the time the blood counts do drop, but then they do pick up. And luckily it's generally quite mild. Nephrotoxicity is not as much as a worry as initially thought. Most of our patients do quite well. We do also see some mild and severe hepatotoxicity, also depending on how much liver was diseased at start of treatment. Two areas where we like to take a bit more caution, where the nervous system is involved. For example, if she's got brain metastases or has metastasis in the spine, vertebral column, or in the mesenteric nodes close to the gut, we like to give some extra dose of steroid over a longer period of time to hope to reduce the inflammation caused by the treatment. Also, when we're giving treatment, we come across scenarios where the patient has actually progressed, and at that stage, unfortunately, we do have to stop treatment. Also, we come across strict discussions when to give salvage re-challenge. I think it's quite established in many parts of the world. We ourselves are also, if the patient has responded in the first 18 months of treatment, we do offer them if they have progressed after. So dosimetry, ongoing discussion, in an ideal world, yes, it would guide us, but it is time consuming and labor intensive. Most of the place I worked before and where I'm working now, we don't really do it. And then of course there's the financial strain. It's expensive, and obviously there's a bit of difference in pricing. So always there is a pressure to make sure we time the patient right to receive the treatment and we do not waste the dose, really. So some cases. So this was a young female who was 26-year-old, diagnosed with pancreatic origin, metastatic neuroendocrine tumor. She received 4 cycles of PRRT, and she had complete response, and she was followed up for 8 years, and she's remained in remission. Another case of a patient with mainly osseous metastatic disease, received 4 cycles, also complete remission, was in remission for 7 years follow-up. Another patient with massive hepatomegaly and metastases responded really well, so I'm showing you the happy best cases here. And patient was disease-free for 5 years post follow-up. This is a patient treated at Shaukat Khanam Hospital. So this patient with rectal endocrine tumor responded initially. She had very good response. She had a good response after initial 4 cycles. We went on to rotate PET CT. This is how we do things here. 4 cycles, PET CT, and decide if we want to give 2 furthermore. Because we saw response and there was residual disease, we went on to give her 2 more cycles with further response. Unfortunately, I'm almost done. Unfortunately, she progressed and was referred to us for salvage or re-challenge. We did give her cycle 7, but unfortunately she progressed despite that, developing ascites and effusions. Another patient we've treated, which was outside the guidelines. We did have to get special permission to treat him, left adrenal feo, and he's now received 4 cycles, and his norepinephrine, norepinephrines have come down. He's clinically well. Disease is still there, and we're having ongoing discussion whether to stop at cycle 4 or to give 2 more. Yeah, so that's it. Thank you very much.